Now, a little bit further down now, we want to talk about thyroid nodules and thyroid cancer. And I want to tell you, before we do a case, I want to tell you a little bit about thyroid nodules, because before a patient is diagnosed with thyroid cancer, remember, they don't come in saying I have thyroid cancer. They come in and they say, I got a nodule on my thyroid, or somebody found a nodule on my thyroid, or somebody sends this patient to you because they did an exam and found a thyroid nodule in the and they want you to further investigate it. So here's a couple of the rules that we live by when it comes to thyroid nodules. If a thyroid nodule is non-toxic, non-functioning, it is presumed to be cancer until proven otherwise. So if the thyroid nodule is not causing hyperthyroidism, if it's not actively secreting thyroid hormones, if it's not toxic, that is considered to be thyroid cancer until proven otherwise. On the other side of the coin, if a patient has a thyroid nodule, and this patient has hyperthyroidism, so you assume that this is from that nodule, that this patient has toxic nodular goiter, the chances of thyroid cancer are 0. You don't go doing anything to that thyroid nodule because you assume that this is toxic nodular goiter, and if a patient has a toxic nodule, then that patient has 0 chances of thyroid cancer. So basically, when you see a thyroid nodule, your first step is to really assess, does this patient have a functioning thyroid nodule, or is this a non-functioning nodule and I need to think about cancer? And the way you do that is you do a good clinical exam to make sure the patient has no symptoms of hyperthyroidism, and you check a TSH. If the TSH is normal and the exam is normal, then this is a non-functioning thyroid nodule, and that patient has a chance of cancer. I hope everybody understands that we have to exclude 100% of the time thyroid cancer. Now, they tell us some other stuff. Now, you know, nodules that have higher suspicion for thyroid cancer are people that have the highest chance of having thyroid cancer are people with thyroid nodules who've had a history of radiation to the head and neck area. Please be careful of that, because anybody that has a thyroid nodule and they have a history of radiation to the head and neck, this is cancer. It's cancer 9 out of 10 times. Now, they may not tell you, you know, they had radiation to the head and neck. They may tell you this patient 20 years ago got treated for stage 1 Hodgkin's disease. Stage 1 Hodgkin's disease, you know, was treated with local XRT to the head and neck area, right? So that's the kind of stuff that they're going to tell you, that you have to know. So anything about XRT to the head and neck area, that's cancer. Anybody that has a nodule and has lymphadenopathy around the thyroid, right, or in the clavicular area, that has a high suspicion, even higher suspicion of thyroid cancer. Men have a higher chance, if they have a nodule, to beat cancer. Even though most nodules occur in women, women are much higher chance to see a thyroid nodule in a woman, but most of their nodules are benign. In men, because it's rarer to see a thyroid nodule, if you see one, you should have a higher suspicion of thyroid cancer in men. And then elderly patients, when they have a thyroid nodule, elderly patients, you got to think about thyroid cancer even more. But the bottom line is, non-functioning thyroid nodules are cancer. You have to exclude cancer. So what do we do in these patients? Well, take this case here. A 32-year-old man comes for the evaluation of a neck mass, right? You find a 2.5 centimeter thyroid nodule on the left thyroid lobe. There's no lymphadenopathy. The vitals in the examination are otherwise normal, with no evidence of thyrotoxicosis. So they're telling you the vitals in the examination are otherwise normal, with no evidence of thyrotoxicosis, and they'll have here that the TSH is also normal. So I'm going to give you that we checked even the TSH, and this patient is normal. What's the next appropriate step in this case? And the answer is a fine needle aspiration of the thyroid gland. please, I want you to make sure you understand this. If a patient has a non-functioning thyroid nodule, the next step is to do a fine needle aspiration of the thyroid nodule. You don't do radioactive iodine uptake scans. You don't do ultrasounds. You do a fine needle aspiration. In over 80–90% of the time, you'll have the right diagnosis and confirm the diagnosis. Is it benign or is it cancer? And they have to go and get a thyroidectomy. The reason why we don't do ultrasound, because even a cystic mass there, even if it's a cystic mass, you could have thyroid cancer behind the cystic mass. So a ultrasound showing a cystic mass doesn't tell you anything. Sometimes we use the ultrasound to guide us to do the biopsy. That's okay. That's okay, but we don't do the ultrasound to look for a cystic mass and say to our patient, this is a cyst, I don't have to worry about it. No, we have to do a fine needle aspiration always. The reason why we don't do a radioactive iodine uptake scan, because if a patient has a normal thyroid function, remember you assessed this guy clinically for thyroid function and you did a TSH which was normal. If a patient has normal thyroid function, then if you do the radioactive iodine uptake scan, you're going to get one of two results. You're going to get a cold nodule or you're going to get a warm nodule. The cold nodule has a higher chance of cancer. The warm nodule has a lower chance of cancer, but still has a chance of cancer, so you still have to do the fine needle aspiration. The reason why you won't get a hot nodule is because this patient has normal thyroid function. You're not going to get a hot nodule. A hot nodule is a toxic nodule. So just by doing a good exam in the TSH, you excluded that case. That's why both of these tests, if you do the next step in this case, you either get a radioactive iodine uptake scan or you get an ultrasound. That's the wrong answer. It's the wrong answer because that's not what you do. You do a fine needle aspiration. If a fine needle aspiration is done and it shows an adenoma, right, benign, you don't forget about that patient because sometimes you could miss the cancer. So what they ask you to do is, what do you do after fine needle aspiration? It shows benign adenoma. You say, okay, fine, this is benign adenoma. What do? I bring them back 3, 4, 5, 6 months later to make sure this hasn't grown in size. If it grows in size, then you have to rebiopsy it. If there's any lymphadenopathy later, you have to biopsy it. They may ask us sometimes, some patients have multiple nodules. Well, which nodule do we biopsy out of the multiple nodules? And the answer is, we biopsy the biggest nodule. You pick the biggest nodule, and that's the one that you biopsy. They sometimes ask us, a patient that has had a fine needle aspiration of a thyroid nodule comes back a year and a half later with a new nodule. What do we do about it now?